Hello, everybody. My talk today is about ARDS, and my contention is that we do not need the definition of ARDS. Let's see. These are my conflict of interest. As you all know, ARDS, acute respiratory distress of the adults, was defined in 1967 in the Lancet, and the respiratory distress syndrome was defined as a disease or a syndrome with acute onset of tachypnea, hypoxemia, and loss of compliance. PEEP could be used, and steroids too. And it actually corresponded to a rather common appearance on the chest X-rays with bilateral involvement and diffuse involvement of the lung with whiteout of the lung fields because of loss of aeration of the lung. The fact is, however, that most people at those times were not talking about ARDS, but rather about severe acute respiratory failure. And I just give you two examples. This is the first randomized controlled study in critical care conducted by Warren Zeppel about ECMO in 1979. This other is another big study with more than 300 patients conducted by Bob Bartlett and published in 1986. And he was talking about acute hypoxic respiratory failure. However, a lot of confusion was around about how to define and how to call this acute respiratory failure or acute respiratory distress syndrome or hypoxemic respiratory failure. So when you cannot agree on something, you make a consensus conference. And in 1994, a consensus conference was held in the States between American and European scientists to define the concept of this new syndrome, very common in critical care unit, and the consensus about acute respiratory distress syndrome was reached in 1994. However, in 2012, this definition was slightly modified, and in the definition, you need hypoxemia, more or less severe, plus the use of positive end expiratory pressure, at least 5 centimeters of water. The syndrome, the disease should start acutely, and the edema should not be due to cardiogenic lung edema. However, the most important difference between acute hypoxemic respiratory failure per se and acute respiratory distress syndrome was the need for bilateral opacities. If you have opacities just in one side, it's not ARDS. And the conceptual definition of ARDS was originated by the idea of diffuse lung inflammation. And this is a paper by Kaplan and Schuster showing the difference between pneumonia and ARDS. In pneumonia, you have increased permeability just in the region where you have lung collapse, while the rest of the lung is almost normal as permeability is concerned. In ARDS, you have increased permeability due to inflammation all over the lung field. This is a study by Bellani with positron emission tomography showing that, as a matter of fact, lung inflammation as measured by glucose, fluorodeoxyglucose pickup by the granulocytes is diffuse even to the aerated regions of the lung. and not only to the collapsed region. So the conceptual model of the ARDS, the thing that the definition should catch is the concept of increased permeability and diffuse alveolar damage, edema, inflammation, hyaline membrane formation, or hemorrhage inside the alveoli. Unfortunately, when the Berlin definition was checked with pathology at autopsies, out of more than 340 ARDS patients, 159 only had diffuse alveolar disease. So the definition does not really catch the idea of diffuse lung disease and diffuse inflammation. Moreover, ARDS, as the name tells you, is not a disease, is not a single disease, it's a syndrome that can be due to many diseases, from malaria to vaginal granulomatosis. We have tens and tens of cases of reasons by which a patient can incur into the acute hypoxemia and the ARDS. And moreover, even physiologically, they might be very different. Like in this paper, Papazian showed that some patients do respond dramatically to the application of PEEP, like in the top patient here, a good recruiter. Some do not change at all because they do not recruit anything, any lung tissue. Or indeed, we studied some 300 patients with COVID-19 ARDS. The overall mortality was pretty high, 35%. But you see, we divided patients into 4 groups: high dimers and high compliance. Dimers were supposed to suggest intravascular thrombosis. Then we had high dimers and low compliance, low dimers, high compliance, low dimers, low compliance. And you see that patients with high dimers and low compliance have a much higher mortality than all the others. So the concept is that within ARDS, we can have many different phenotypes, amenable probably to many different treatments. And as a matter of fact, there is not a single drug that is effective for all ARDS. And even protective lung ventilation is even worse, because it's not good just for ARDS, it's good for every ventilated lung, even if ARDS is not there. We studied a few thousand patients in 500 critical care units over the world. We called it the Lung Safe study. We enrolled 12,000 patients, out of which 4,500 had acute hypoxemic respiratory failure. Of those, 3,000 had ARDS, that is, 3,000 had bilateral involvement of the lung. So, but the point is ARDS really different from acute hypoxemic respiratory failure? Once again, we studied 4,500 patients with acute hypoxemic respiratory failure. 2,600 had ARDS, 851 only had unilateral lung disease. And unilateral lung hypoxemia had a mortality significantly lower than ARDS. However, when we compare patients with 2 lobes involved one side, and this is not ARDS, it's acute hypoxemic respiratory failure, with patients with 1 lobe each side, at the end, the mortality is the same. And so the only difference between ARDS and unilateral acute hypoxemic respiratory failure is conceptually non-existent, because the severity is only different according to the number of quadrants involved. So at the end, if we look at the classification of acute hypoxemic respiratory failure patients, we see that the Berlin definition includes the conceptual model, but is not limited to the conceptual model. Moreover, there is no real difference between the Berlin ARDS and acute hypoxemic respiratory failure. So the difference are really non-existent. And we could probably conclude, like Jean-Louis Vincent did 4 or 5 years ago, that do we need the definition of ARDS as opposed to acute hypoxemic respiratory failure? Do we really need bilateral lung involvement? Perhaps ARDS is a very good and useful conceptual model, but in clinics, the ARDS definition includes the conceptual model, is not limited to it, and probably we could clinically very well survive with the definition, much simpler definition of acute hypoxemic respiratory failure. And with by that, I think I have expressed my concept, and I thank you very much for your attention.